Good afternoon. Today we'll have a lecture about rheumatoid arthritis in general medicine. After finishing it, I will also deal with some slides of the allergy lecture, and the allergy lecture will be completed tomorrow, also with the lecture that is for tomorrow regarding immune deficiency disorders. So we'll take half of the allergy lecture today and half will complete it tomorrow. But our main lecture today is about rheumatoid arthritis. The allergy lecture is not that long. The aims of this lecture is to discuss about rheumatoid arthritis, definition, pathogenesis, clinical manifestations, laboratory diagnosis, differential diagnosis, management. These are the theme of the lecture. What is rheumatoid arthritis? It's persistent inflammatory arthritis. دائمي. There is no cure from it. Persistent inflammatory arthritis with exacerbations and remission. Sometimes it comes in exacerbation, increase in the symptoms, and sometimes remission in decrease and stable condition. The prevalence is about 1%, 1.5% among European people, female to male, 3 to 1. That is to say, more in females. Mortality rate is increased by cardiovascular system. These people cannot tolerate to have with their condition cardiovascular system, so they will be disabled. Disability 40% in 3 years, 80%, 80%.
دكتور ما في صوت.
سوري muted لأن حكى معاي فرات. على كل حال المحاضرة كان منزلها بس صاير ايرور، هلا نزلها مرة تانية. تمام
دكتور.
اللي حكيته قبل الميوتيشن البور prognosis. We said the most aggressive year is in the first year of the condition. Poor prognosis if the patient have disability in a presentation, at a presentation, female gender, metatarsopharyngeal joint, which are the joints in the feet, smoking, positive rheumatoid factor, positive anti-CCRP. These are all of them show poor prognosis. These are signs of poor prognosis for the patient. That is why you have to start aggressive treatment early. Genetic and environmental homozygous have concordance rate about 12 to 15%. Means it has genetic element. Heterozygous المختلفين about 3%. شو معنات concordance rate؟ يعني عند التوينز الاثنين بيصير عندهم نفس المرض. اسمه concordance rate. AGLI DR4. DR4 remember it. 50 to 70% present in rheumatoid arthritis. In normal population it is 20 to 25. شو معنات هذا؟ معناتها انه ال HLI-DR4 is also involved in the pathophysiology of rheumatoid arthritis. Why this? CD4 more severe and erosive disease. Also other HLI types, DR1 and DW14 in some nations, but mainly DR4. Smoking and breastfeeding also may trigger the disease. You know, we said that there are exacerbations and remission. Smoking and breastfeeding may trigger the disease. Synovial membrane infiltration. The main problem in rheumatoid arthritis is the synovial membrane infiltration. Lymphocyte, mainly CD4, as you know, CD4 cells, T cells, and the plasma cells. Activated T cells stimulate B cells to produce the rheumatoid factor, which is the autoantibody and anti-CCP. Macrophages also are involved in the pathophysiology of rheumatoid arthritis. They produce different cytokines. In the following picture, we will see what cytokines are involved in rheumatoid arthritis. Now we talk about cytokines and pathophysiology. Endothelium cells also, synovial fibroblasts, bone marrow cells, chondrocytes, all these cells share in the pathophysiology of rheumatoid arthritis. There is swelling and congestion of synovial membrane. We said the main problem is in the synovial membrane. Then there will be destruction of the bone, cartilage, and soft tissues around the joint. That is why there will be disability. The main cytokine will be tumor necrosis factor alpha, which can regulate other cytokines. So in our treatment, we are going to target the tumor necrosis factor. We give anti-TNF alpha. Also, the B cells will produce the autoimmune autoantibodies. And these autoantibodies can form immune complexes, IC immune complexes within the joint and extra-articular tissue leading to vasculitis. So vasculitis is due to the formation of immune complexes. The tissues, lymphoid tissues, due to the stimulation, are formed within the synovial membrane. And I will come back to these lymphoid tissues. Panas, there is what is called panas or clothes. This is a granulation tissue spread over and under the articular cartilage. عارفين بالjoint في cartilage. Above and beneath the cartilage, there will be an inflammatory granulation tissue. This is called panas, which is then the cartilage will become eroded and destroyed progressively. Later on, after destruction of the bone and the cartilage, there will be fibrous and bony ankylosis. يعني زي التيبس. Fibrous and bony ankylosis. And once the joint is not used, there will be muscular atrophy. أي joint rheumatoid nodules. Here the R is rheumatoid nodule. Consists of central area of fibrinoid surrounded by mononuclear cells. These are similar to granuloma lesion. They are present at many areas in the pleura, in the lung, pericardium, sclera, in the skin, and we will see some pictures for them. Rheumatoid factor synthesis in the synovium, we said, and in the lymphoid tissues, which become hyperplastic, as I said a moment ago. So you can see here the pathophysiology of rheumatoid arthritis. Dendritic cells, which are antigen-presenting cells, they present the antigen to the T cells. So you can block this antigenic stimulation of the T cells by a beta sept, monoclonal antibody, which will block the antigen presentation. The T cells now change to Th17, which are part of the pathophysiology of rheumatoid arthritis. These play a role in autoimmune diseases. They secrete interleukin 17 على اسم الخلية, which stimulate macrophages. The macrophages produce interleukin 6, which stimulate the liver to produce acute phase of protein, like CRP, for example. Macrophages retain to produce interleukin 1, which stimulate Th17, and also produce TNF, which stimulate the synovial fibroblast. The synovial fibroblast now produce ADAMTS S5 MMP, which can erode the cartilage. The macrophages produce rank L, which destroy the osteoclast and cause erosion of the bone. This can be blocked by monoclonal antibody, which is called denosumab. Interleukin 6, as I said, can be produced here and here, can be blocked by anti-IL-6, which is called tocilizumab. Th17 also can do stimulation of the B cells together with interleukin 6, and these B cells will produce autoantibodies. The autoantibodies can form immune complexes, as I said, and cause vasculitis in the blood vessels. And the TNF here can be blocked by anti-TNF. If you look at this picture, which is simple picture, you can see that that the treatment will become obvious with these monoclonal antibodies, abatacept, tocilizumab, denosumab, anti-TNF, and anti-B cells, which is rituximab, to prevent the formation of autoantibodies. Clinically, from clinical, of course, the patient will suffer from pain with this joint swelling and joint destruction of the bone and cartilage, and mainly the small joints are affected. Remember, large joints can be affected, but the main pathology at small joints. And we will talk about these small joints in the hand, in the feet, at the wrist. Also, large joints may be involved. Systemic and extra-articular manifestation may occur. So we have articular at the joint and extra-articular outside the joint. The criteria for diagnosis, we have a table, I will show it to you, which can be used for epidemiological purposes. Symptoms should stay more than 6 weeks. يعني انت مو واحد عنده joint pain اسبوع واحد تقول rheumatoid arthritis هذا لا. The symptoms should stay more than 6 weeks until you can say this could be rheumatoid arthritis. It can come as very acute onset. We said exacerbation and remission. morning stiffness, polyarthritis. Polyarthritis يعني many joints, pitting edema, and it is common in older age group. Palindromic, what is the meaning of palindromic rheumatoid arthritis? It means relapsing remission, relapsing remitting with exacerbation and remissions. This may take hours to days, this remission period. The criteria for diagnosis, التفاصيل هذه غير مطلوبة منكم، بس we can say that it depends on the joint affected. You can see that the small joints contribute more to the diagnosis than the large joint. بس هاي الفكرة. Serology, the positive for rheumatoid factor and anti-CPA, anti-citrullinated peptide antibody in low titer or high titer contribute more to the diagnosis. A duration, it should be more than 6 weeks, otherwise you get zero. Acute phase protein, حكينا أنه تزداد الأكيوت phase protein بالروماتويد arthritis يعني CRP and ESR. Patient with a score 6 or more considered to have definite rheumatoid arthritis. فأنتوا عليكم بالفكرة الجوينتس السيرولوجي الديوريشن والacute phase reactant 6 or more points could be diagnostic to the rheumatoid arthritis. Examination of the hands. You have as a doctor to examine the hand which reflect the disease activity. The joints affected symmetrical, right and left. The swelling of metacarpopharyngeal. عارفين انتوا الميتاكاربوفارyngeal. And the proximal interphalangeal, proximal. Distal are not affected. If you see distal affected, this is not rheumatoid arthritis. So symmetrical, metacarpopharyngeal, and the proximal interphalangeal. Joint will be tender, stress pain, effusion, and swelling. Deformities, varieties of deformities. We will see them in the pictures in a moment. The swan neck, botnier, Z deformity of the thumb, dorsal subluxation of the ulna at the distal radio-ulnar joint. راح نشوف هذه, which indicates tender rupture. In the foot, the same thing as the hand. Dorsal subluxation of the metatarsophryngea, which will be cocked up, يعني يرتفع إلى الأعلى القدم. Eversion, انحراف القدم نحو الخارج. Calcaneo valgus it is called. شو معنات calcaneo valgus? Is eversion of the foot, leading to flat foot also. Popliteal cyst, which is called Baker cyst, with knee synovitis. It comes with knee synovitis. Usually Baker cysts are present behind the knee. This is, look, botnier. This is deformity. عكس البوتنير السوان neck. Okay, السوان neck, I will show it to you. This is the swan neck. Okay, يعني مثل رقبة الزرافة أو البطة. Sorry. Right, so botnier, swan neck. This is ulnar deviation. These are the joints which are involved. Metacarpopharyngeal and the proximal interphalangeal joint. The distal are not involved. This is botnier again. This is the swan neck. There will be atrophy of the muscles here, weakened muscles, ulnar deviation, and varieties. هذه الأشكال غير مطلوبة من عندكم، بس يعني من تشوفها تعرف أنه these comes with rheumatoid arthritis. Z shape of the thumb I will show you other pictures for the Z shape of the ulnar deviation. Uh, this is the subluxation, volar subluxation at the wrist, radio-ulnar subluxation. And you can see the rheumatoid nodules also at this area. This is rheumatoid nodule present in the skin and present at other places. I will show it to you also. Look here, this is the ulnar deviation, and this is this one neck, okay? And these are some swelling present in the hand due to synovial swelling at the wrist. If you see this X-ray, you see symmetrical destruction. This is normal on the right side. This is the normal hands X-ray. This is for rheumatoid arthritis. Look at the destruction at the metacarpopharyngeal and the proximal. Look, symmetrical. The distal are clear. No involvement. Extra-articular features, anorexia, weight loss, fatigue, متوقعة. Osteoporosis, muscle wasting, which is called sarcopenia. Now, the extra-articular features are common in seropositive erosive disease. What are the seropositive? The seropositive, the cases which are positive for rheumatoid factor and anti-CCP, or called anti-CPA, the same thing. Now, these extra-articular features may come with serositis, granuloma, nodule, or vasculitis. Now we discuss the cutaneous and vascular features of rheumatoid arthritis. Rheumatoid nodule, which are present in seropositive patient. يعني لو واحد عنده rheumatoid nodule, شفت عنده rheumatoid nodule, you should not send the patient to test for rheumatoid factor or anti-CCP. The patient will be certainly positive for these autoantibodies. So patients with rheumatoid nodules are positive for autoantibodies. They are present on the extensor surfaces of the forearm or the sacrum. Because you know the extensor surfaces at the forearm is the area, or sacrum is the area at which the patient may lie on. It may ulcerate and become infected. Rheumatoid vasculitis, we said vasculitis is due to immune complexes. We can see them mainly in old patients, vary from nail fold infarct, nail bed become black in color, to cutaneous ulceration and skin necrosis. This is vasculitis due to immune complexes. Mesenteric renal coronary artery occlusion may occur also due to the vasculitis. Extra-articular manifestation, you can read them: systemic, fever, muscle wasting, anemia. Look here, thrombocytosis. I stress on this point. Rheumatoid arthritis is associated with a thrombocytosis. Be careful, okay? And in the lymphatic, there is what we call Felty syndrome. I will discuss Felty syndrome in a moment. Many areas are affected: bursitis, osteoporosis, eosinophilia, splenomegaly, ocular. Eye damage can occur: episcleritis, scleritis, scleromalacia, keratoconjunctivitis sicca. I will explain to you these 4 items in the eye. Vasculitis everywhere. Cardiac, pericarditis, myocarditis, etc. Pulmonary nodules, rheumatoid nodules present in the lung, which are called pulmonary nodule of rheumatoid arthritis. Kaplan syndrome, I will explain it to you. Also neurological manifestation, cervical cord compression. Also, I will show you a picture for that. Amyloidosis, any chronic disease you have taken it in your pathology, amyloid will be deposited at different tissues. This is Kaplan syndrome. Rheumatoid nodule, these are the rheumatoid, pulmonary rheumatoid, together with pneumoconiosis. Pneumoconiosis, it means the coal mine. So the coal miners العاملين بالفحم الحجري يصير ترسبات عندهم باللنج and rheumatoid arthritis and pneumoconiosis called rheumatoid arthritis plus pneumoconiosis called Kaplan syndrome. You can see the intrapulmonary nodules. These are the intrapulmonary nodules. Okay? Rheumatoid nodules, these are rheumatoid. Such a patient will be positive for what? For rheumatoid arthritis, for rheumatoid factor. I'm positive for anti-CCP. Within 10 minutes, the time will be expired and we have to re-enter again. Okay? Immediately we can re-enter again. Also nodules were palpable. This is here bursitis. Ocular involvement, we said keratoconjunctivitis sicca. It means dry eyes. Is due to secondary Sjogren syndrome. The patient may have secondary Sjogren syndrome. Keratoconjunctivitis sicca. And it can be treated by artificial tears, دموع اصطناعية, as eye drops. Episcleritis, the condition is painless. Usually comes with nodular seropositive. Scleritis is painful. On the other, the patient may lose insight, while episcleritis, the patient does not lose sight. يعني لا يفقد النظر بالإبيسكليرايتس ولكن يفقد النظر بالسكليرايتس. Sometimes painless scleromalacia, thinning of the sclera, so the choroid will appear as a blue or gray in color, called scleromalacia. Painful corneal melting usually come with vasculitis and leading to perforation of the cornea, and this condition requires steroid and immunosuppressive therapy. Look, this is episcleritis, mild, painless. This is scleritis, more severe, dangerous. The patient may lose the sight. This is keratoconjunctivitis sicca, and artificial eye drops can be, tear drops can be put in the eye just to make it wet. Cardiac and pulmonary involvement. It occurs in 30% who are seropositive for rheumatoid arthritis. Pericardial effusion, pericardial constrictive pericarditis. A granuloma anywhere, causing heart block in the cardiomyopathy, coronary occlusion, aortic regurgitation. A here is aortic regurgitation. Serositis, pleurisy, pulmonary fibrosis can occur. So rheumatoid arthritis can cause pulmonary nodules and pulmonary fibrosis. So if you listen by stethoscope to the lungs of the patient, you will get crackles. Crackles are due to the presence of fibrosis. Now, neurological complication. We said we can have a neurological complication, median nerve compression, carpal tunnel syndrome. Remember last year I taught you the carpal tunnel syndrome with MSS. Ulnar nerve compression at the elbow and wrist also. Lateral popliteal nerve compression at the head of the fibula. Peripheral neurotarsal tunnel syndrome, similar to carpal tunnel, but it occurs with the posterior tibial nerve compression. Mononeuritis multiplex, it comes with vasculitis. Cervical cord compression, this is due to the dislocation or subluxation at the atlantoaxial joint. The joint between atlas and axis, you know, axis is C1, atlas is C2. So there is subluxation between these two, C1 and C2, and it may compress the spinal cord, and it may kill the patient. If the patient with rheumatoid arthritis has got occipital headache, you should take care about him and take images to the area of cervical spine and occipit to see any subluxation present at the atlantoaxial joint. You can see here the subluxation of cervical spine. This is in flexion. This is in extension. You can see that there is widening of the gap between atlas and you can see subluxation between atlas and axis. And this is a very dangerous condition. As I said, it could be very dangerous and maybe killer. So between odontoid edge of the axis, which is behind, and the anterior arch of the atlas, which is in the front. Other complication, amyloidosis, which can result in nephrotic syndrome, macrocytic anemia, iron deficiency anemia from NSAIDs. This patient takes NSAIDs frequently. So they have normochromic normocytic anemia, NN, normochromic normocytic anemia, and the thrombocytosis in active disease. Remember, thrombocytosis. Felty syndrome, the patient will have splenomegaly, neutropenia, rheumatoid arthritis, and the thrombocytopenia, you can add it. Thrombocytopenia in Felty's syndrome. Also, the patient will suffer from lymphadenopathy. So we can take biopsy because the patient may have risk of lymphoma. So Felty syndrome, what is Felty syndrome? You have to take care from the criteria of Felty syndrome. The risk factor, patient above 50 to 70, female more than males, Caucasian, يعني الشعوب الغربية, more than a black, long standing, deformity but inactive disease, seropositive for rheumatoid arthritis. Common clinical feature, splenomegaly, lymphadenopathy, weight loss, skin pigmentation, keratoconjunctivitis sicca, vasculitis, recurrent infection, nodules. Lab finding, normochromic normocytic anemia, neutropenia, abnormal liver, thrombocytopenia. Remember here, thrombocytopenia, impaired T and B cell immunity. Investigation, diagnosis, usually the diagnosis is clinical, but we do tests to confirm the diagnosis and to assess the disease activity. There is a score called DAS-28, remember this, DAS-28, to assess the response to therapy and the need for biological therapy. You can assess the activity of the disease by DAS-28. So we can assess also with it, not only the activity, but the response to therapy. The higher the value, the greater the disease activity. Also, ESR and CRP, acute phase protein, will be increased. Rheumatoid factor and anti-CCP, or called sometimes anti-CPA, anti-citrullonated peptide antibody. Anti-CCP, anti-citrullonated peptide antibodies. Anticyclic citrullonated peptide antibody, cyclic citrullonated peptide, present in 60 to 80%. In Middle East is less than 60 even, maybe 50%. Anti-CCP is more specific and occurs before the onset of the condition. So if I ask you which one you prefer to do, rheumatoid factor or anti-CCP, of course you are going to choose the anti-CCP. Plain X-ray of the hands, the wrist and feet, you will see erosion. Don't send plain chest X-ray of the hands only. You have to send for the feet also. Sometimes the condition appear earlier in the feet than in the hands. I always send a plain X-ray to the hands and feet. MRI and X-ray for atlantoaxial